So today we have Dr. Shannon Rotolo, who is a pharmacy education coordinator at the University of Rochester Medical Center. She completed her PharmD at the University at Buffalo School of Pharmacy and Pharmaceutical Sciences and her postgraduate training at the Golisano Children's Hospital at University of Rochester Medical Center. Prior to her current role, Dr. Rotolo spent over a decade working with pediatric and adult patients who require complex or high-cost therapies. Her clinical expertise is in the management of cystic fibrosis, asthma, and pediatric lupus. Dr. Rotolo served as a board member of the Illinois Single Payer Coalition and on the PNHP Illinois Advisory Board during her time in Chicago. She is a founding member of Pharmacists for Single Payer, and she currently serves on the PNHP National Board. Thank you so much for being here with us today.
Thank you for introducing me. I will share some actually before I even pull anything up on the screen. From this group, did you all watch a pre-recording, like about 20 minutes worth of a previous year's session? Nobody? Okay, great. That's totally fine. And then I will just treat this like it's completely fresh content, um, which is more fun anyways. All right, let's see. Do, 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 do. What did I just do? Is my screen sharing now?
Yes,
Okay. Let me put that in a prettier view. That looks good.
perfect.
All right. Okay. So a lot of potential areas for intersection between single payer and for myself as a pharmacist and pharmacy related things. Today, I'm going to focus in on pharmacy benefit managers and community pharmacies. And it will make sense why I think as we go in terms of the impact that our current healthcare system has um, on patients, on sort of the structure of how we do pharmacy and drug related things here, and other other little fun, not fun elements. So as a starting point, I know that you all have had many sessions and have probably heard this many times, but just to like be aligned on the same page, here's how I think about what single payer is. So when we're talking about single payer, what I'm thinking about is a single public agency organizing healthcare financing. And that should include all medically necessary services, whether or not you see that completely or that explicitly in different legislation, different Medicare for all bills, different maybe state-based single payer bills, can be a little bit variable, right? But the ideal vision of single payer would include all medically necessary services. So that means, of course, medical things, inpatient, hospital stays, outpatient visits and clinics. Also dental, also vision, also prescription drugs, which is most of what we'll focus on in this session, medical supplies, and long-term care. And then the other thing about single payer that I think about when I say comprehensive is that it covers everyone from birth to death. Um, what single payer isn't. So it doesn't include cost sharing in an ideal world, right? Which is not consistent with all the Medicare for all bills that we've seen proposed in recent years, meaning that it doesn't include any co-payments, doesn't include any deductibles, but it's also not a national health system, right? So it's not kind of the structure that we would think about from the UK. In that the delivery of healthcare services continue to be provided mostly by private businesses, whether that looks like a hospital um, in a community setting potentially, or if that looks like a brick and mortar pharmacy, but not necessarily some organized provision of healthcare. So kind of as a roadmap for our talk today, this will sound sort of like objectives, but maybe not that formal. Um, I would like all of you to be able to recognize what the heck is a pharmacy benefit manager, which I believe Dr. Weisbart has talked about or will talk about a little bit, but maybe just giving a little bit more context to that and a little bit more context to how they fit currently into our healthcare system. Um, and then I want to talk about the impact of those pharmacy benefit managers on community pharmacies and sort of how that impacts our patients in terms of drug prices, medication access, and then how that impacts other people in healthcare roles, whether that's pharmacists, physicians, other folks with prescriptive authority, sort of like what the interplay of all these things actually looks like as it rears its ugly head in all of our respective careers. So what does our current system now look like for prescription drug benefits, right? If we want to think about where we want to get to in a single payer model, let's think about where we are right now. So we know that we have a number of payers, right? Not a single payer. So that includes a lot of private health insurance companies. That includes Medicare. That includes Medicaid. That includes Medicare Advantage plans that contract with PBMs. That includes Medicaid managed plans in some states, right? Where there's multiple options rather than just a classic fee for service plan in an individual state. Um, so we have a number of payers that exist. We have pharmacy benefit managers, which I'll kind of show you how they play within this game in the upcoming slides. And then we also have pharmacies that are providing the actual medications and billing these other entities. And that can be the pharmacy chains, like the big box names that you would recognize. That can also be smaller independent pharmacies, sort of like the mom and pop pharmacies. And we'll kind of talk about what's happening in terms of that landscape in later slides. So what is a PBM, that middle section of the last slide? So pharmacy benefit managers oversee prescription drug benefits on behalf of large health insurers. So that could mean on behalf of like Blue Cross Blue Shield or Aetna or what have you, like whatever the big health plan is in your area locally. Um, that can also mean on behalf of Medicare and Medicare Part D drug plans. And that can also mean directly on behalf of large employers. So I usually use as an example something like Coca-Cola, right? That is a large enough employer that they actually could be contracting directly with a pharmacy benefit manager rather than working through a health insurance company for that contract. Um, and what those contracts entail, we'll see on the upcoming slides. But kind of there's a lot of sort of entities interplaying. So what you're going to hear me or see, I guess, visually on the upcoming slides, see demonstrated is the transfer of funds, which will be actually not in blue, I don't think, in green arrows. And then the transfer of services or what services are supposed to be provided on pink arrows in the upcoming slides. Hopefully that'll make sense as you see it. So I'll start with PBMs and pharmaceutical manufacturers because that is probably the most straightforward of the relationships. Um, so a PBM is the group that is setting a formulary for any large health plan, maybe for a specific employer if they're large enough to contract directly with a PBM. But when you go to the pharmacy counter, if you're, wondering if something's on the formulary, the PBM is the group that's kind of crafting that formulary for your health plan. So the relationship between PBMs and pharma is an incredibly messy thing, despite there only being two arrows on this slide, where you'll often hear these two groups kind of uh, finger pointing at one or the other, right? If I worked for a PBM, I would say the problem with drug prices in this country is big pharma charges too much, and the PBM perceives itself as maybe being there to help by negotiating for the best possible price. Um, Pharmaceutical companies would say, no, 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 the problem with drug pricing in this country is PBMs who, demand these large rebates and there's no transparency to pricing because PBMs exist and no one's sort of paying the same price. It's all this incredible negotiation. So these two, not two groups, and that there's many, many drug companies, but there's sort of a fraught relationship between pharma and pharmacy benefit managers. Um, there's also this relationship between PBMs and health plans. So I said before, health plans are often contracting with the PBM rather than the employer themselves contracting with the PBM. to just deal with all that drug stuff. Like the health plan is used to billing for hospital stays, used to billing for office visits, has a whole infrastructure around how those things are done. Health plans historically have not really dealt with drugs. Like that's not their area of expertise. They don't mess with that. They contract with the PBM to get a list or formulary of drugs to handle all the billing stuff because pharmacy billing happens in real time, which is why you can pay your copay right at the counter at a pharmacy, as opposed to hospital billing or even office visit billing, which is often happening a month after the actual encounter, right? Like many of us have, heard about surprise bills from hospitals or maybe had the experience of like you get a bill many weeks later. Um, that's sort of more the process is a little bit on the back end for like medical benefits, whereas pharmacy benefits, again, it's that real time electronic transmission of billing that's happening. And that's why patients are kind of presented with a copay right at the counter, right at the point of service, which looks a little bit different than other spheres of healthcare. So the PBM's relationship with the health plan is they handle the formulary management. They handle that sort of rebate situation with pharmaceutical companies. Some percentage of those rebates get passed on to the health plan. There is not a lot of transparency in what that percentage is to anyone other than the PBM. So the health plan doesn't really know what percentage of the rebate they're getting based on those formulary management negotiations. And then the health plan is also um, paying the PBM for administrative fees, cost of drugs, and dispensing fees anytime a member on that health plan picks up a prescription. But you'll notice the health plan is paying the PBM, not the pharmacy. So that kind of brings us to the PBM's relationship with the pharmacy. So the health plan has given the PBM some amount of money every time you go pick up your generic Lipitor, let's say. Um, each month. The health plan is, not for that individual charge, but the PBM will amass, a spreadsheet or an invoice of all of the charges of all of the members of that health plan's prescription pickups that month or whatever the cadence is that they're running this report based on their contract with the health insurance company. The PBM is in real time as that electronic processing is happening, is transmitting payment to the pharmacy for the drug. That payment, which we'll talk about on an upcoming slide, doesn't always match the amount we saw on that previous slide. So the health plan and PBM will be contracted that, let's say, every time someone on the health plan fills a prescription for Lipitor, the health plan will pay the PBM. I don't know, let's say that it's $5 just for a simple, number. Um, the health plan pays the PBM that amount, whether the PBM passes on $3 of that to the pharmacy or $3.50 to the pharmacy or $4 to the pharmacy. Why would those numbers be different? We'll talk about that on a future slide. But so the PBM's relationship with the pharmacy is that the PBM is responsible for sending the pharmacy payment for the drugs based on the cost of the drug plus the dispensing fee. Um, and then the PBM also sort of hands over to the pharmacy a contract to dispense for covered patients, meaning if we have a contract in place, if I am the PBM, I will actually send you money every time you dispense a drug at this rate and with all these other details and contingencies in the contract. So when I show the arrow going from the PBM to the pharmacy, that's really intentional. And the pharmacies and certainly independent pharmacies don't have a lot of room to negotiate those contracts. This is not a back and forth. This is not oh no, but we want our pharmacy to be reimbursed $4 for Lipitor because we buy it for $3.80. This is a nope, the contract is what it is type of situation. With little to, I would say, no wiggle room in that. And I think that's going to mirror what you guys will hear about um, contracts and like being a network with different insurances as a physician as well, or within like as an office, as a hospital or a health system, as an individual physician that works at a certain hospital, right? To be a network, you are kind of taking the conditions in these contracts like as they are given and don't necessarily have a lot of negotiating power. Is sort of the point I want to make with the direction of that arrow. Um, and that kind of brings me to the definition of steering. So what if I am a small independent pharmacy and I want to turn around to the PBM and say, this contract is garbage. I'm not going to refuse to do courier service to patients who are unable to leave their house to come to the pharmacy to pick up and force them to use a mail order instead. I have a courier service and I'm happy to provide it to these patients. There's no, you can't force me to not. Um, I thought I had another slide there. Um, well, the PPM can say, well, that's too bad. Okay, that's fine. Don't take the contract. And then the position that pharmacy is in is not being able to dispense for any patients and get reimbursed for them, that have that health insurance, right? So if that was the situation that occurred between an independent pharmacy and a PBM, where the independent pharmacy says, no, I'm not going to take this contract based on XYZ condition in it, then if I, as a patient, show up to that independent pharmacy thinking I can get my medication filled there, well, I can't get my medication filled there and use my insurance coverage or my pharmacy benefits coverage because that pharmacy doesn't have a contract with my pharmacy benefits manager. Um, and so what this can end up doing is steering patients to the pharmacies that PBMs find that will accept whatever those conditions are. Um, I know I've got a slide later that will bring us back to this idea, so we'll talk about it a little bit more then. But this is pretty messy, right? Like there's a lot of arrows going a lot of places. You notice the PBM is sort of in the middle of it all, right? Kind of this extra middleman, if you will. And the one person we haven't talked about a lot in this whole infrastructure is the patient. So what's the patient's experience or interface with a pharmacy benefit manager? Literally nothing. So this middleman is pretty invisible to you as a patient. Um, you pay your premiums to your health plan, right? You pay your premiums to Aetna, not to CVS Health, or your employer passes along, their portion of your premium to this health plan. And based on that, you expect the health plan to provide certain services, right? Like you expect that it's going to be covered if you show up in a hospital after a serious accident or with the condition that warrants that level of care. Um, when you go to the pharmacy, you expect to show up with your copay and that the pharmacist will provide you with your medication, some education on that medication, especially if it is new to you. And depending on what state you live in, I would say the majority of states, um, in fact, require pharmacist education or counseling at the time of a new prescription pickup or at the time of any change with the medication. So if your dose doubles, right, you expect your pharmacist to go over that with you, let you know what to expect, um, that things will look or be different. Um, it's kind of what you're actually interfacing with as a patient when it comes to the sort of pharmacy side of care. But at no point do you have a direct contact for the PBM. At no point would you even know that this entity exists unless you end up down some really weird rabbit holes. Um, the other group I didn't talk about on the previous slides are wholesalers. Wholesalers are the groups that purchase medications from pharmaceutical companies and then sell those to pharmacies. I am not going to say that there's nothing ugly within those relationships, but it is certainly a lot less complex than the rest of the screen, and it won't be the focus of our talk. Um, so it kind of hinted at on the previous slide that the amount that the PBM receives from a health plan for any prescription that's filled does not necessarily correspond to the amount that the PBM then sends to the pharmacy. That difference between those two amounts is something called spread. So this is one of the places where PBMs can make their money in addition to rebates. Is on spread, right? That like, yes, you get a certain administrative fee or whatever in your contract with any given health plan, but you're also kind of padding that up or increasing your revenue by increasing your spread. So the more you can get a health plan to pay you for a drug and the less you can actually send to the pharmacy, the higher your shareholders' value goes up as a PBM. This already sounds a little dirty, right? Even in the sort of name of the game, capitalism in America, right? A little it's a super non-transparent process. We don't really know how much is getting passed on between these different players. So it's kind of weird to begin with. The place people get really actually riled up about this is when that health plan is a Medicaid plan and the PBM is contracted by a Medicaid plan that's doing sort of a managed care approach rather than a fee for service approach. Um, because that skim or spread that's coming off of between those two numbers is certainly not being actually used for healthcare goods or services, but is paid for by taxpayers. So that's one of the places that like this actually will occasionally draw some attention. There was a really big um, expose in Ohio done related to spread. Same thing happened a few years later in Florida, where a group actually looked at and analyzed how much spread was happening with some of the state-based Medicaid plans, which again relies on taxpayer money, right? So that's one of the places where you can get people to like actually sort of pay attention to this issue, as people have a lot of feelings about how their tax dollars are spent and is one of the sort of opportunities to engage the public on this. But it certainly is not a thing that happens exclusively within Medicaid plans. This is something that happens in basically any PBM and health plan arrangement. Sorry, I had animated arrows there. If you had watched a previous version of this talk, you would have seen a much simpler slide about vertical integration. So when I mentioned PBMs using contracts as a tool to kind of set unacceptable conditions, sometimes for independent pharmacies, they're really incentivized to do that. Those contracts should be as terrible as possible for the pharmacy, right? There should be an incredible amount of spread and very challenging conditions for that pharmacy because they don't actually want to include independent pharmacies in their network. They don't want people who are connected to the health plan that they are contracting with. They don't want those patients using just any old pharmacy. They want those patients using a pharmacy that is owned by their parent company. This didn't used to be an issue 15 years ago. This is a huge issue now where we're seeing tons of vertical integration in the healthcare space. So certainly we saw this very early on with pharmacy benefit managers, and with retail pharmacies. That has only exploded as the number of specialty drugs, both in the pipeline and now out on the market, have exploded. And there's a lot more sort of money to be captured there, a lot more revenue to be captured there. And then I know that you all have probably heard that we're seeing this type of vertical integration in other spaces in healthcare too, in terms of hospitals turning into health systems, private equity starting to buy some of these practices. So I won't, that's certainly not my area of expertise, and I won't go into that in a lot of detail, but you can kind of think of those things as sort of the mirror images of each other, like the medical side and then the pharmacy side. We're both seeing this incredible amount of vertical integration and unfortunate focus on shareholders and business relationships rather than on patients and the healthcare professionals who take care of them. Um, I also think it's interesting. I like to highlight the middle column here with CVS Health specifically. So there was a time a decade ago as these integrations were really taking off and starting to happen and gain big waves in the media in terms of attention, where you would see the insurer buying a PBM. Um, that flip has really happened thanks to that PBM integration with retail and then later specialty pharmacies and those incredibly large margins that can be made in that part of the market where CVS Caremark actually bought Aetna, not the other way around. Um, so when you think about kind of who the power players are on these slides, it often is at this point, um, in terms of what things look like in the marketplace, it's the PBM that has the cards, not the insurer, which I think is really interesting and isn't necessarily intuitive based on how small um, of a spend you would expect there to be associated with prescription drugs, but the amount of revenue that can be made there, the margins are just a lot wider for these types of companies, specifically those that have integrated specialty pharmacies. So I'm going to take a little pause here and see if there's any kind of initial questions, or I know that was like a lot of arrows and a lot of different pieces. Was that okay to follow? Any early questions at this point? Okay, and then it'll get a little bit more fun as we move on. But that's like the complicated stuff in terms of the background. Um, so we've seen like sort of the relationship, the sort of exchange of money going here and there, services going here and there, between the PBMs and some of the different entities. Um, but what roles or functions are PBMs really offering, and what would happen if we had a single payer system and just totally eliminated PBMs? What would that look like? So if you look at PCMA, which is the lobbying group for PBMs, they will tell you that PBMs are so important because of these four things on this slide. The first is formulary management and exceptions processes. So if you've ever needed a drug that wasn't on your formulary as a patient, your physician or other prescriber probably filled out a prior authorization form. That prior authorization either got approved or it didn't. Um, that prescriber or someone else in the office who is delegated that task probably filled out an appeal or didn't if it didn't seem worth fighting for and there were other options. That appeal may have been a paper process that may have involved a phone call, like a peer-to-peer phone call with the insurance company, a lot of different structures for that. So currently with PBMs as the group or groups in this case that are managing formularies, you end up with literally like thousands of different formularies across the country for thousands of different plans. It is very popular for a large employer who contracts with a health plan who contracts then with a PBM to request certain specific things on their formulary. These are called custom criteria by the PBM. So you literally do end up with thousands of plans across the country. So it's really hard for folks that are in roles where they're prescribing, so physicians or PAs or NPs, to know what's going to be covered under any patient's insurance. Pharmacists don't know what's going to be covered under any patient's insurance until they actually run a claim, um, which we can talk more about that later. But it's sort of a guess, right? What is on any one patient's formulary, unless they're maybe in some states you'll have a state Medicaid plan that's like clearly posted on a website somewhere, but that's like sort of your best case scenario. The rest is like maybe you can log into a portal and maybe it's roughly close to the standard plan that PBM is showing on that portal that you may or may not even have a login for if you even know which one your patient's insurance is contracted with in the first place, right? Just incredibly messy, incredibly inconsistent. And then that prior authorization plus or minus appeal plus or minus peer-to-peer phone call process I described is really different across all different PBMs, all different plans. So it may be that initial turnaround time is 24 hours on a prior authorization if you file it electronically online, through whichever portal or through an aggregator portal. It may be that it's a 48-hour turnaround. It may be that it's a 72-hour turnaround. It might be that it's a week turnaround, and you don't know what to expect as the office. So in terms of your process or workflow for when do you follow up on this, who the heck knows? It's a different amount of time for every patient. If you do indeed get a denial letter from a company, okay, well, how do you appeal it? Again, literally thousands of plans. The process could be different. The expected turnaround time could be different. The amount of time you have to even file that appeal may be different. Um, so this is just all to say in a very long-winded way, an incredibly messy process with PBMs as the entities doing formulary management, right? No transparency, you don't know what to expect versus in a single payer system. People love to ask me like, well, wouldn't there still be prior authorizations? Yeah, there would, but what if it was one consistent, transparent process where we knew exactly what to expect when a patient really did need something unusual, and we knew exactly what the steps we needed to take were to move that process forward versus this total guessing game based on a patient having any one of thousands of plans. Um, so, so yes, prior authorizations probably do not go away in a single payer model, but they probably make a heck of a lot of sense, and we all know what to expect from them. In terms of other things, PBMs will say that they do so well. They talk about their negotiating power. There's some truth to this. There are three major PBMs and only like some dozens, maybe still, of smaller PBMs. So when you have that many, they call it covered lives in their industry. When you have that many covered lives, right? You have, I don't know, 5 million Americans on your plan. Yeah, you have a lot of negotiating power with pharma. But this is sort of a silly argument if the alternative you're comparing that to is single payer, where you have literally the entire US population as your number of covered lives. So again, that consolidation, that one transparent and consistent process would make for not only lower drug prices, because that's an incredible then amount of pressure on pharmaceutical companies if there are not multiple PBMs to pit against each other, but simply one formulary for the country. Um, and again, results in that kind of transparent and clear reimbursement rates for pharmacies so that they know what to expect when they're purchasing a drug, whether or not they're actually going to get reimbursed at or above cost for it versus below cost. Um, PBMs will also kind of tout their ability to restrict networks. Um, that's not something that would exist in a single payer system. And to me, that is a feature of single payer, not a bug, right? So if I perhaps I'm a person who lives in a really rural area. I don't want one of the three pharmacies within 25 miles of me to be the only one that I can use based on my insurance plan. I want to be able to use any pharmacy that's within driving distance of me and go to the one where I feel like the pharmacist is someone I trust, or the one that is an easier commute than the others, or the one that has hours that better fit my work schedule so I can actually go get my medication on time each month. Or maybe it's the one that has a courier service so they can drop it off at my door when I don't have time to get to the pharmacy, but that pharmacy still exists and has a brick and mortar location if I did need to go get a flu shot because my annual PCP visit was off cycle with flu season, right? So I think the less restrictive we can make it, the more we can improve access to every healthcare professional, including pharmacists, as actually, again, a feature, not a bug of single payer and not really something that PBM should be touting that they do so well, restricting networks. And then the last thing PBMs will say that they do is reduce waste and improve adherence. Um, the specific data on this are really challenging to find, but you will certainly find um, a lot of anecdotal information and a lot of opinions from folks that have worked in the pharmacy world, like myself. Um, the the things the PBMs think they're doing to reduce waste are not always in fact reducing waste, right? Like if a PBM were to report out, oh, well, we denied X thousand prescription claims this year, and only half of those ended up later being filled or got a prior authorization or were substituted with another agent. Well, half of people went without a medication that their physician thought they needed then. That's not reducing waste. That's not meeting people's needs. And like, is there some percentage where like, I don't know, maybe in 0.8% of those situations did the prescription actually get written for the wrong drug, right? And it was like because of a prior authorization block that was realized that it was, oh, they meant to click whichever button, clicked this button when prescribing, and the wrong claim went through. Sure, yes, maybe in like 0.8% of cases. I would like to think that most of the time the pharmacist would actually identify that you probably didn't really want, I don't know, 80 milligrams of morphine, and you may have clicked the wrong button and called the office to clarify that, right? Rather than it really requiring some kind of PBM hard stop to be the thing that would have stopped that claim. Um, But so I think that, the way they define reducing waste is essentially the way I think of primary non-adherence, meaning the patient never actually started the medication. That doesn't mean that waste was prevented, sorry. It just means the patient never got their drug. So I think that's like sort of an interesting way to sort of, I, I guess just to say that you can't really trust the numbers or statistics on that because you don't have the full amount of details the way that is reported. And then in terms of improving adherence, so again, a lot of these PBMs are specifically steering to their own affiliated or like vertically integrated pharmacies. Um, if if you are CVS Health, and I'm going to pick on CVS a lot because my husband used to work for that company. If you are CVS Health and you really want to show that patients are adherent to medications if they use CVS pharmacies, well, what are you going to do? You're going to enroll them in an autofill, and you're going to make it really difficult to unenroll from that autofill. So that patient may have been told to stop that medication. They may be taking it at a different dose or quantity, and the prescription hasn't yet been updated, but every single month they're still going to get that delivery. Um, that doesn't actually improve adherence. That expands the stockpile that person has in their medicine cabinet or in their fridge, right? So if you're only counting the amount of drug dispensed as adherence, some of these vertically integrated companies can make some pretty compelling cases that their patients have great adherence. Um, but if you've been the pharmacist on a like telehealth visit with one of these patients and you watch them open their fridge and see literally thousands of dollars of medication sitting there because they've already stopped that kind of insulin or had to make a change based on what their needs were, that's not improved adherence, right? That is actually waste in the system. So I left a bunch of question marks there. I think you can tell based on my own experience, probably what I think, how I think that would really fall out. But I will say it's something that's incredibly difficult to quantify, and I always am really skeptical when people want to talk about specific numbers related to that. Does that make sense, or any questions related to that? The last thing that this lobbying group doesn't list, which to me is actually the most important, like sort of core function of like what are PBMs doing, is nothing on this slide. It's actually pharmacy claims processing. So I mentioned earlier on that pharmacy benefits are processed, like the claims are processed in real time, right? Like when you go to the pharmacy counter, your pharmacist can tell you what your copay is going to be. You literally never have gotten a surprise bill from a pharmacy, probably, unless I will say there's a small exception of people who are on medications that are billed through medical benefits but are supplied by pharmacies. And like those claims are subject to the same craziness that happens with medical benefits billing in general, where you actually probably could get a surprise bill after the fact, like a month later. But in general, I think the one thing that PBMs get right, and in fact, their like initial purpose was to handle that real-time claim processing. Um, th- that's pretty key for pharmacies to continue to be functional. Pretty key in our current system for patients to um, know what the cost of a prescription is at the time of service. That would be a little less essential in a single payer system, but I think even more importantly than that, you could centralize and consolidate that process too. Like it already does go through a centralized hub. So to me, the one thing that's actually valuable that PBMs provide would be really easy to have a streamlined single entity do. It doesn't need to be PBMs anymore. That's not some special technology that only they have. So that's let's see, we're a little bit before 3. How is everybody doing in terms of, do we need a break yet? Good to go for a little while longer? Okay. Um, So that's kind of the messy background of our system and sort of our current system compared to single payer. But I do want to talk a little bit more about the impact of that on patients and on pharmacists, just so you all have that understanding as you move forward through your careers and continue to interact with pharmacists and other healthcare professionals in more settings, kind of what what those other healthcare professionals might be seeing and how to pull them into the fight for single payer. Um, so we'll start out with drug prices and cost-related medication non-adherence. And to break things up a little, we're going to start with a game. If you had watched a pre-recording, guess what? You have no advantage because I updated these based on 2024 drug prices. So it's some of the same drugs that I used to talk about, but it's it's a little different in terms of the actual numbers now. This list is actually specifically the reason there was such transparency around the prices for the drugs that are on these slides is because they were all drugs included in the Inflation Reduction Act. We don't have to talk about that more here. This is already a pretty complicated talk, but if you are interested in talking about that more at a later time, let me know. But that's where this list of drugs comes from, and this is immediately prior to the implementation of the Inflation Reduction Act. Okay, so our first drug is Eliquis. And you all can just type in the chat. What do you think this bottle of Eliquis would cost? Without insurance, just regular, what is the price in the US? If you're like, Shannon, that's a trick question. There are so many different prices for medications in the US. Which type of price do you mean? I know. Just a guess. There are wholesale prices, there are net prices, there are, GPO prices, but those are all pretty similar to each other. So, I can tell you in other countries, this bottle's $64 in France, $45, $91 in Germany, uh, $72 in the UK, and in Canada. You guys are going for like 300s, 200s here. Yeah, you're right. So in the US, that same bottle costs $249. So a little bit more. So I guess our 200s are the closest without going over. Um, yeah, a little bit more than other comparator peer countries, if you will. How about Xarelto? I guess I should have said Eliquis and then Xarelto too. Are people already familiar with these drugs based on where you are in your training? Do you know what these do? So these are two of like the most popular. Actually, everything on here is a really high use drug, which is why it got selected for the Inflation Reduction Act. And um, yeah, like a high use drug specifically among people that are Medicare eligible. So both of these are blood thinners. I won't be more specific than that if you're not there in your school yet. But so kind of a comparator or competitive product with the previous product. So we might be expecting a similar price. We're seeing it's pretty cheap in Australia. Gets a little more expensive in Germany. Okay, what's going on there? Germany's got an interesting system, right? Like they're also not a true single payer. They're just like regulated to death, so they almost function like a single payer, but like, more on that with someone who's more of an expert another time. But sort of a different system than some of these other comparator countries. Um, Seeing though kind of similar numbers here to what we saw on the other slide, right? Kind of higher end of the range. We're looking at 60s to 70s. The US, $206. So yeah, pretty similar to its competitor product, right? Um, but certainly way higher than what other countries would be able to purchase that for. All right, next up we have Januvia. Does anyone recognize this one? It's a very blurry picture. Generic name is sitagliptin, if that gives you a clue. So this is a medication often used in diabetes. It's not that expensive, right? Like in France, you can get this for like 20 bucks. What do you guys think this costs in the US? Closest without going over. A little bit more in Canada. Okay, Canada's also not like a true single payer system. They've got some weird things going on with their pharmaceuticals, right? All right. Wow, these numbers are all over the place now. All right, $117 in the US for 1 month, right? Or actually, this isn't even a full month. This is a 4-week packaging, right? This will not even get you through 1 month. $117. How about Novolog, right? Like maybe you have diabetes and that previous age, if you have type 2 diabetes, I guess. Type 1 diabetes, you're getting insulin, but type 2 diabetes, right? Maybe that previous oral agent was pretty pricey and you want to know, can you manage your diabetes just with insulin? Insulin's got to be cheaper, right? That's the guy who patented it, sold it for what, $1 for that patent, right? Because everyone should have access to insulin. It's kind of looking pretty variable already in other places, right? Yeah, so $134 for this isn't actually based on vial size. Sorry, this is the equivalent of 30-day supply. $134. So this isn't really like a cost savings compared to the like, newer agent, right? This drug is as old as dirt. But we still in the US have pharmaceutical companies charging upwards of $100 for uh yeah, just a month of therapy that is literally like essential for someone with type 1 diabetes to live, right? It's kind of wild. Um, this one we already know is going to be more pricey. This is Enbrel. So this is a biologic. Can be used in what, rheumatoid arthritis, a couple other things. But essentially is yeah, a biologic or immunomodulating agent. So this is going to be kind of pricey anywhere, right? Like we're seeing 500 plus dollars in other countries. Um, we kind of expect sometimes Germany, sometimes Canada will be outliers, but like no, even other places, like this is getting a little kooky. What do we think this is in the US then? This would be a good one for the $1 million meme. So over $2,000. So like maybe percentage wise not as bad as some of the other ones, right? Like this is only slightly more than double the next closest competitor, but more than double the next closest, right? Like what is going on here? What is going on here is that drugs in general are more expensive in the US. And it doesn't matter which way you slice it. So I have a couple of slides that are going to say the same thing, that drugs are more expensive in the US. And I don't care if you're talking about that as percent of GDP or if you're talking about that in terms of actual wholesale cost or any of those other crazy ways that we determine costs for pharmaceuticals. It doesn't matter. They are all going to be more expensive, whatever way you want to slice it. So that is, you'll see a few slides about this. It's true no matter which way you think about it. And actually, the cost of drugs is rising. So this slide's a little dated now, but I can tell you that this continues to be true. That if you look at some of the top selling drugs in January when the like pricing updates come out from different pharmaceutical companies, top selling drugs, you are always going to see about a 5% or more increase in the cost of those drugs that doesn't correspond to inflation. It's like regardless the cost of these drugs is going to go up 5 to maybe like 10% in some cases. It doesn't correspond to them getting new FDA approvals or, indications for therapy. It doesn't correspond to anything. They just do it in January because it's what they do. Um, so you'll see that across the board with pharmaceuticals. But in some of these cases, right, like this is definitely trending more than 5% change per year in this 5-year time period that this article in JAMA looked at. Um, I also think that it's interesting that you will often see drugs in the same category increasing by the same sort of like exponential rates. So like Novolog, Humalog, both insulin products, both short-acting insulins, right? So direct competitors. And you would think, and I used to see this with when I was in my specialty pharmacy role a few years back. I used to see this with very specific drugs for pulmonary idiopathic fibrosis. OFEV was like the really big one of them. And then with its competitor as well, it's not a race to the bottom, right? It's a race to the top. They will see their competitor increase the price and be like, oh yeah, we can do that too. So all the things that people talk about, like the pressures of capitalism, um, do not hold true in this system if you're thinking about it in terms of what you learned about economics and other places in your life. And it's actually patients, not hospitals, that take on a lot of these price increases. So this is some work actually by a pharmacist that I used to work with and two of our former residents that I was very excited to see them publish. So they were really focused on drug purchase price volatility within healthcare systems or like within the hospital setting. But if you look at the numbers, both in their study and in other work that is looking at trends in prescription drug expenditures, um, when these prices increase, it's not the hospital, and likewise in the outpatient setting, it's not the health plan that's eating that change in price, right? It is patients. These changes in prices get passed on to patients across the board, sort of regardless of setting. So that was actually for in his case, this is someone who worked in like a pharmacy management type role in his pharmacy residence that he trained specifically for health system pharmacy. So like they were, maybe happy with the outcome in their paper. If you were to pull this article, they'd be like, the good news is, as someone who manages a hospital pharmacy in the inpatient setting, where we don't have to worry too much about these costs because they end up getting passed on to patients. But like that's actually a terrible thing, right? Like it depends on what framing you're looking at that through. So for him, yes, for like his specific role, sure, it's a good thing, right? The hospital is not gonna go under due to the increased cost of drugs, but a huge problem for patients. And just incredible that, we already know intellectually or through our experiences that that is a big problem in the outpatient setting, but wild to see even in the inpatient setting that again, it's just passed on to patients and people just go bankrupt for medical debt in our country. And this gets even more like just sad for patients with either complex or devastating diseases. And what I'm talking about here is specifically specialty drugs. So we see this wild increase in the revenue that people who make oncology drugs and other specialty products were able to make over the years. But patients are seeing higher copays at the pharmacy counter, but also higher premiums, right? And I may have a slide on that somewhere later. I'm not sure if I do. Patients are seeing higher premiums than ever before, right? So, like, if you work somewhere that does provide you health insurance, the amount that you're individually contributing to that has gone up over time. And the amount that your employer is contributing to that has gone up over time. And it's not proportional with the changes in other benefits that employers might be providing for you. It's much more dramatic, and it's certainly not proportional with people's salaries, which means that Americans are actually probably getting paid less than they should be, which we know Americans are getting paid less than they should be, right? Like we know our minimum wage is terrible, all those things. I'm assuming everyone's a little bit left leaning, but I guess not everyone who's into single payer is. But I'm assuming you would probably all agree with me that like minimum wage in the US is pretty abysmal, and we have a lot of problems in general with people getting fair pay for their work. But isn't that incredible, right? That like like why does that happen? Some of it because employers just y'all can do better, but also some of it because employers are spending that additional money that they are spending on employees each year on their freaking health benefits for that employee to turn around and still have higher premiums themselves and higher copays than ever, right? Like it's just wild. Um, so yeah, again, our drug spending already higher than other countries, already increasing faster than what we see in other countries if you're talking peer matched countries. Um, and just yeah, well, like that ultimately does have that consequence on patients who these price changes get passed on to. So what does that look like when I say that high drug prices hurt patients and that's who's like bearing the burden of this? One of the easiest ways to talk about that is in terms of cost-related medication non-adherence. So I like this study because they sort of surveyed a pretty wide cross-section. Um, compared to some of the other things I'll include here, but I did try and include a representation of this in specific groups as well. But I like this one. It's pretty wide range. A lot of other countries. You'll see like the next worst is Canada's like a lot worse than everybody else if you like just ignored the US, right? If you just like put your hand over the final column and pretended it wasn't there. Canada looks a lot worse. Canada doesn't have a single payer system for drugs, right? And that's why at the beginning of this talk, when I talked about what does an ideal single payer system look, or what does that ideal payer system look like, it has to include prescription drug benefits, or you don't fix any of this. And maybe you actually do fix a little bit of it based on Canada's example, right? But like, they're still just so much, if you ignore the US, they're so much farther off than all of these other countries. Um, so I guess also like to give context, what does this mean? Um, Actually, I don't know. I don't know if I remember now in the study the way they categorized it. So I'll tell you this one because this is more clear on the slide. So slightly more recent data. This was looking at adults between 19 and 64 years of age, which means they're not going to be eligible for Medicare, right? Like this is below Medicare age. So these are people on probably private insurance or maybe on Medicaid. Um, Specifically doesn't include children either, so adults of quote working age. Um, So I think what's really interesting about this one is like roughly a third of patients are not filling a prescription at some point in that calendar year because of the cost of the medication. Um, you kind of see this breakdown a little differently, like so that number could be a lot lower if everyone had consistent insurance. So again, going back to those very early slides, consistent coverage from birth to death, right? Being a feature of single payer. Um, People being insured continuously, not having gaps in insurance because they lost their job, right? So this is a really good representation of um, if you're insured but had a gap in your coverage, that group is the most likely to not fill a prescription because of cost, right? Maybe you switched jobs. Maybe you started medical school and previously you were on your parents' insurance and now you're on some other insurance independently, or you turned 26 or whatever it is, right? So some of you may have had this experience and maybe you weren't on a high cost medication where you had to make this decision, right? But if you were on a brand name inhaler for asthma, you may have been in this boat, right? Where maybe the month that you had a coverage gap, you were like, I could probably just take it once a day instead of twice a day until my new insurance kicks in. And that's the kind of, decisions folks are having to make during coverage gaps. Um, so yeah, I think what I want to highlight with this is that those transitions between different coverage are really, really impactful. And that's why you see higher numbers with that group, even above folks that are uninsured. Um, is that having a disruption in your coverage is a really big deal beyond just the actual prices themselves. Um, and even folks who are underinsured but have consistent insurance are maybe not in a quote better position, but more likely to fill a prescription versus avoid that because of the cost of it. Um, this is just kind of breaking this down in a different way for the following year. They didn't present the data in exactly the same way, but they didn't show it with that coverage gap. But this just kind of reinforces that, yeah, you can have insurance, but if you're underinsured, that's also going to be a potential barrier to filling a prescription. Um, this is the same slide again. Did I just go backwards? Okay, yeah, I did. And then I said there were other examples that maybe were not as robust as that first study that I showed that's a little bit older. But I do just want to highlight cost-related medication non-adherence happens across age groups. It's not just in that working age or not just in that senior age group that we saw in the original study that we looked at. And then it happens across disease states. So these are specific examples that really break this down, get a little bit more detailed within very specific patient populations, but it doesn't matter which patient population you're talking about. You can be talking about COPD, you can talk about rheumatoid arthritis, which has some high cost specialty drugs. You can be talking about diabetes, which again, insulin, old as dirt, like this should not be expensive anymore, but it is. You're going to see cost related medication non-adherence in any of these disease states and across age groups. Um, Oh, this I think is a little more interesting than the um, data about just prescriptions being skipped. So this was a survey that asked individuals about what exactly are you doing when you're not filling that prescription that month, or maybe you are filling the prescription, but like, are you doing something else to try and um, muddle your way through the cost of your medication? Um, And these are all like behaviors that I've seen in my patients when I worked in direct patient care roles. So delaying filling the prescription, right? Like, I'll probably be okay without it for a week, and then I get paid on the first of the month, and I'll fill it then. Just not filling it completely, fully skipping that month, right? Using less medication. So maybe that's that asthma example I talked about. You're going to take your inhaled corticosteroid just once a day instead of twice a day for a while. That'll be fine, right? And a lot of times it will be fine, and sometimes it won't be fine. Um, so using less medication, intentionally skipping doses. So I guess using less medication would be more like, oh, I cut the tablet in half, but I still took it every day. I just took a half tablet. Or using someone else's medication, which I don't know. That's I will save that for a non-recorded time to talk about that. But as absolutely a behavior that I've seen. Um, Sometimes people will be able to identify, or with the help of their pharmacist or a very helpful pharmacy technician, will be able to identify copay cards or coupons to help with costs of medication. Oftentimes, people will return to their physician, right, and say, "Hey, I never started this drug." If you're lucky, maybe they'll tell you that within that week, but maybe you'll see them 3 months or 6 months or a whole year later, and they'll be like, "Hey, I never started this drug. It was too expensive," right? Because they're I don't know. My mom is a great example of this, that person that's like fearful to tell her physician that she didn't do the plan, right? So she just says nothing. And then 6 months later, her A1C is still high, right? So, like, I love my mom very much. She's one of those, like, help me, help you people. So my mom is a great example of that, right? Won't even ask until things have already gotten worse. People will sometimes shop around at pharmacies to try and get a lower price. This has really been incentivized by GoodRx. I don't think I have anything about that in this talk, but I've worked with a couple of groups where we've done some cost comparisons with like things like GoodRx and how this impacts patients in terms of actual financial versus logistic toxicity. So we can talk about that more if that's interesting to anyone. But like the shopping around is really just not ideal for a number of reasons that we can get into. Um, they try to find financial assistance. So there are occasionally like grant funds, things like that for patients. I sifted through a lot of those when I was in a specialty pharmacy setting, working with really complex patient populations. But this is certainly not something that's available to everyone. Um, People going without basic needs to afford medication. I can tell you what that looks like for my days as a pharmacy intern. That looks like you are at the pharmacy at your grocery store. Does anybody live in an area? I know my fellow Rochester friend will think of Wegmans probably, right, as somewhere where you can pick up a prescription at the grocery store, but I guess Publix is a good example for, I don't know what's in California. What's your guys' uh grocery chain with a pharmacy in it?
We have like Safeway,
Okay.
Albertsons.
Okay.
Um, I would say those are the two big ones.
Okay, that's probably comparable. Wegmans is like the very small version of something like that, a little more local, like regional, I guess now chain. But I remember being a pharmacy intern and you'd see someone walk up with their new prescription for, I don't know, maybe their kid's antibiotic, whatever it was, that they really did need to pick up that prescription, and also their cart of I don't know, milk, eggs, bread, like basics. And you literally see them make the decision at the pharmacy counter. Oh, that antibiotic for my sick kid costs how much? Oh, okay, I guess I don't need these couple items in my little basket of the, 10 things you're willing to check out at the pharmacy counter for me. Oh, I guess I don't need this basket at all. Which is insane when that's, oh, I guess we don't need milk and bread this week. I guess we don't need eggs this week because I have to buy my kid's antibiotic prescription. Um, so like that's the pharmacy intern back in the day experience of like literally watching what that means and that real time sort of calculus for families. Um, People bring in prescriptions for other countries. It's a whole different thing we could talk about if anyone wants to. And then borrowing money or going into debt, right? So some percentage of medical debt is, of course, related to prescription medications. I think we see that more in the oncology space with like the really, really high cost stuff, but across the board is certainly possible. Um, Other things related to medication non-adherence and outcomes, like as you can sort of guess, there is a cost to non-adherence beyond just like the health cost to that patient. If you have type 1 diabetes and go without your insulin, well, that insulin probably actually, despite how much we're charging people for it in the US, only cost a fraction of what the ICU stay for diabetic ketoacidosis is going to cost, right? So there's like economic numbers tied to this. I personally am not particularly interested in those because I think about it more of the framework of like what's the patient's experience than like what's the cost to the healthcare system of our drugs being too expensive. Like I don't know, our whole healthcare system is messed up. So like that's to me is like such a minor thing, but people who really care about those things, which are probably some of the people you'll talk to and encounter in the advocacy you do in your career, I think that's another good thing to keep in mind if you're talking to someone who literally just cares about the numbers. The non-human element of this, like the numbers are also like if we just spent a little bit more money on making sure everyone could afford their medications, we could save an incredible amount of money downstream in terms of the sort of catastrophic outcomes of not having access to those. Um, so like how does single payer help with this specifically? So yeah, we could bring down drug prices by, and this is again, like you can tell which part of this I'm the most interested in, but like, yes, we could bring down drug prices by consolidating that negotiating power, instead of multiple PBMs doing that, just all of that being for one country. And projections are that that could bring up to a 50% price decrease on brand name drugs, which is pretty consistent with what you saw on a lot of the slides with US prices versus other countries that had single payer systems, right? So that sounds right, like that tracks. But to me, it's really the second bullet point, removing the cost burden from patients entirely. No copays on medications of any kind is really an ideal single payer setup. And obviously that's going to reduce cost-related medication non-adherence, right? And the both health and economic burdens that end up coming downstream from that. There's a lot more to say on this topic too, and if you guys are interested, this is pretty old now, but PNHP does have like sort of a pharma proposal, they call it. Some of this a lot of this overlaps with the things I talked about. A lot of this gets into like sort of regulations and things very specific to the pharmaceutical interest in the pharmaceutical industry. I think you'll hear a little bit more about that if you haven't already in one of the other talks, not Ed's talk. Who gives that talk? Mm. Somebody that I think will do one of these sessions. We'll talk about like, yeah, evergreening of patents, that kind of stuff. That's pretty heavily addressed in this PNHP pharma proposal. So whenever you talk about bringing down drug prices, the pharmaceutical industry loses their minds and they're like, what about innovation? Um, so just so you have like that greater context when you get this question, most major pharmaceutical companies spend only about 15 to 25% on their revenue of their revenue on research and development and spend at least that much, if not double that, on marketing. And despite all that money they're spending on marketing, they somehow still have money to spend more than any other industry in the entire US on lobbying and actually spend twice as much as what insurance companies are spending. And we already saw that, not specifically insurance companies, but PBMs had this, very organized lobbying group, right, that had all these points about why PBMs are so important and necessary. Um, Pharmaceutical companies are so much more sort of refined and elegant about the way they do their lobbying, and it's insane. There is, I don't remember now what the statistic is, but it's essentially one pharma lobbyist for every elected official in DC. Have you guys heard that? Is it one or two? Three now? I believe it. So it's an incredible amount of money that they throw out at that. So if they tell you they won't have the money for research and development and innovation will suffer, that's not true. That's just what their priorities are. That's just innovation suffers already because that's not where the money is getting spent. So I've prompted myself to take a break here. All right, so the next section I wanted to cover is medication access and pharmacy deserts, which you sort of heard me allude to earlier, but I'm going to kind of tie that together. So non-adherence, we talked a lot about cost-related non-adherence. Non-adherence happens due to other access issues. So to outline it more explicitly, what ends up being created when PBMs do these contracting things and intentionally restrict or limit networks is that you have closures of independent and local pharmacies because either loss of contracts or reimbursement rates that are below what that pharmacy can tolerate and stay in business. And then you end up with pharmacy deserts. So pharmacy deserts are sort of already an issue. If you've ever heard like food deserts before, you probably have like another sort of example there or like, can kind of make that corollary. But similarly, pharmacy deserts, they're not geographically limited. They impact both cities and rural communities, but they do specifically disproportionately impact low-income areas and disproportionately impact people of color. So again, similar to food deserts, if that's a term you're familiar with. Um, there are different definitions used of pharmacy desert in the literature. Number of miles in an urban area, number of miles in a rural area. I think like that level of nuance is really not important. I think more important is just specifically the way that this ends up impacting patients. So I've got an example and these are getting a little rusty now, a news headline out of Ohio, one out of Chicago and the surrounding area. And I spent a good chunk of my career in Chicago, so that's the area I chose to represent here, knowing you guys were going to be from all over the country. But for my Rochester friend, this is actually a huge topic in Rochester right now with the closure of not even specifically independent pharmacies in Rochester, but some brick and mortar locations of some of the chain pharmacies in the area. So Walgreens in certain neighborhoods had closed. I know that Rite Aid is now going to be closing across the city. So we're going to see kind of an uptick in pharmacy deserts within the city I live in now too. So, but it's not just that these things are following me in Chicago and Rochester. It is that the entire country, if you pay attention to these headlines, I'm sure you'll see it kind of local to you, is that pharmacy deserts are a growing problem right now. So the one quote I really liked out of this very deep dive in the Chicago Tribune about that issue in Chicago was that even if medications are affordable, if the pharmacy isn't accessible, there, meaning the medication's not accessible. And sort of great patient example of this, right? I lived on the sort of more west side of Chicago, so you do see like that kind of one blue dot where that's like a true pharmacy desert, and then limited pharmacy access surrounding that there. But worked on the south side of Chicago at the University of Chicago. So that's that very blue area, right? And you'd have patients that had to take multiple buses, right? Like multiple transfers to get to a pharmacy. When they actually got to that pharmacy, what if that prescription did need a prior authorization, right? And then you can't pick it up that day. And now you have to find another time you can go back. And if you're working a job and trying to find childcare for your children and already have a number of things that limit your ability to get to that pharmacy, and now it's an hour there and back because you're taking multiple buses to get there during the limited hours that pharmacy is still staffing itself, or the higher powers that be are still staffing it. This can create a lot of access issues for patients. I had originally added in, oh, these are all Chicago examples. So in addition to the like actual, so this article was really focused at that time on this is back in 2018, really focused on literal like miles from a pharmacy deserts. What we saw continue to happen in the city of Chicago specifically, and I'm sure this is relevant to some other areas, is as our Medicaid plans would contract and become, rather than fee for service, managed Medicaid plans, which is something that happened in that area during I don't know, the early 2020s. Um, if it was an Aetna managed Medicaid plan, if you remember from that vertical integration table, Aetna only contracts with CVS. Or if it was some other managed Medicaid plan. Maybe they were only contracting with Walgreens. Well, if you live in an area that's already maybe one of these gray zones and you don't have very many pharmacies at all and are kind of at high risk for becoming a pharmacy desert, and then the one pharmacy in your area is no longer in network with your plan, functionally you are now in a pharmacy desert. So this happened to like a ton of our pediatric patients during my time in Chicago and was just like really, really distressing for families. Obviously, there was a lot of advocacy work around that. Some of those things got resolved. Some of this influenced future decisions around Medicaid managed care plans in the Chicago and greater, like within Illinois in general. Um, but this was a really messy situation for a lot of families for a while and like with actual health consequences for those children. So, just going to keep the bummer train going. In the Northeast, I have historically included a slide on this just because while I know you guys are from all over the country, the PNHP summer intern program certainly originated in the Northeast. So, a ton of examples from there of whether that's longtime independent pharmacies closing or the true creation of pharmacy deserts in some of these small, more rural towns throughout the Northeast. This is, you know, again, just to further highlight, this is not specific to Chicago, big city, or now Rochester, a medium-sized city, or specific to these more rural areas up in the Northeast. This is really across the country. So in terms of pharmacy access, so all of this terrible, of course. I had at one point, and I would be really curious on the feedback from this group because we're getting pretty far out from the early days of the pandemic now. So I had thrown in a couple of examples of things that happened in the early 2020s, like specifically right around the start of the pandemic. And I'm very curious to hear from you guys, like, do these even like sort of resonate anymore, or is this maybe some slides to replace out for future years of this? So one of the things that I thought about a lot during that time was, this idea of patient choice and flexibility really being key, whether that was, because of things like pharmacy deserts, and if you're excluding the one pharmacy in that area from a network, now it functionally, while isn't actually recorded as a pharmacy desert based on the definition, it functionally becomes a pharmacy desert. Or in the case of those early 2020s, we had a lot of pharmacy lootings, which led to temporary closure during that time, both related to COVID and some other activity immediately pre-COVID in Chicago. So that, yeah, maybe that pharmacy was still a network in that specific neighborhood, but that pharmacy wasn't open and available, and the next closest pharmacy was an extremely far way away. So that was just really unfortunate in that, already having restrictions in people's networks and that limitation in patient choice um, really resulted in people not being able to access their medications or like find, a reasonable alternative solution. The other thing that was going on around that time, and I don't know if any of you will remember this, is that there were a lot of issues with USPS and some of those disruptions and things for patients that are, I don't know if you've ever experienced this from an employer yet at this stage, but some patients literally their plan with their health insurance based on the agreement with the PBM is that it is mandatory for them to only use mail order, not in-person pharmacies. Um, that was a real problem when there were USPS disruptions, and people were not receiving mail service. Um, So to have a plan that like truly just does not contract with local pharmacies, people could not just stop by their local pharmacy and say, hey, there's an issue with getting my mail order medications. Can I get a month's supply here to hold me over? Often when these plans exist, just I guess for more context, there will be specific drugs that are coded in a way where they could be picked up one time, or sometimes it'll be that all drugs can be picked up one time if it's the first ever fill from a brick and mortar pharmacy. So like often antibiotics or like an oral steroid will be excluded, or just any class of drug for that first fill will be excluded. But these are like a real thing that have grown in popularity is these mandatory mail order plans where they won't contract with any like brick and mortar locations. So we saw a lot of issues with that in the early 2020s. The other thing that this kind of brought up was that there's a lot of implications here for public health. So prior to the pandemic, 1 in 8 pharmacies had closed between 2009 and 2015. This tended to impact independent pharmacies, specifically in urban and rural, not so much suburban areas. Um, and what we saw as a result during the pandemic was that those closures could have some really serious implications for public health. So in terms of having somewhere other than like if you live in a pharmacy desert, there is a chance that you also live in a healthcare desert, right? That's maybe less true in like my Chicago example, just based on where some of those hospitals are located. But a lot of other places in the country, right? Like it is a drive and probably an appointment to get to your primary care physician's office. It is a drive to get to your local hospital or emergency room if they are running a vaccine clinic. So for a lot of Americans, pharmacies do end up being a great place when we are in a crisis mode and need wide-scale administration of vaccines, or honestly, just even every flu season, right? Like an incredible number of Americans will turn to their local pharmacy as being a quick and easy access point to get a vaccine. So this really like the sort of pain of those closures was definitely felt during the early part of the pandemic in terms of people not being able to use their local pharmacies because they didn't exist anymore for administration of vaccines. A lot of that being routed through large health systems, or a lot of pressure being put on local offices, which at a time when like distribution of limited supply of vaccine was really complicated and the cost associated with that was going to be really unclear. It might not be something where, the local pediatrician's office who's like barely able to keep the lights on some weeks is able to order some huge supply of the children's version of the vaccine where multiple doses come out of the same vial and you're only going to be able to be reimbursed efficiently on that if you schedule those 10 appointments all in the same day and maybe you don't have 10 kids of that age range in the rural area in which you live to coordinate all on the same day, right? So like just the logistics of that, not having those pharmacies to kind of provide those services was a huge issue. Another thing from not pandemic related from the early 2020s that came up. So with the overturn of Roe v. Wade, restricted access to medications for pregnant patients or those able to become pregnant, was a very serious concern for us at that time. So, PBMs and large chain pharmacies tend to have, um, goals of minimizing exposure to potential legal ramifications. So one of the challenges with having chain pharmacies be the largest sort of like slice of the pie in terms of existing pharmacies is that for better or worse, because we may talk about this again later, um, if one state has more strict regulations than other states or more strict laws than other states about when a pharmacist can or cannot dispense, whether that's Plan B or mifepristone or whatever, um, those chain pharmacies now have to respond to what the strictest state is doing. And sometimes they do implement a specific policy within one state only, but sometimes that policy gets implemented sort of company-wide, right? Meaning that you might live in California, but if you try and go to CVS, they are responding to the strictest law in whichever, red state of your choosing that year that has now passed a law that impacts Plan B or mifepristone. Um, and you may not be able to access the product that you need in some of these situations, right? So that was a really big concern and part of why we saw a lot of like mifepristone stockpiling by health systems and other organizations that knew that they were going to continue to provide these drugs regardless of what other states were doing. We don't need another break now, so we'll just roll into our last section. So this will probably be the least interesting to you all, but I hope you at least keep a little warmth in your hearts based on this for pharmacists as you encounter them in the future. We can be a very frustrating and rules-based group of people, but we are often picking up your phone call after a really challenging situation based on some of what this healthcare system looks like. So please give us an extra minute to breathe and a little bit of grace. So what is the patient experience at the pharmacy counter and what's the other end of that look like? So maybe you bring in, sorry, I'll go back. Maybe you bring in a prescription for a new medication that you're supposed to start. And the pharmacist or the pharmacy technician, takes that paper script from you, or more likely in 2025 is receiving it electronically and goes to process it before you even get to the counter. And they're, met with a rejection from the insurance or specifically from the PBM, right? That's who's doing the real-time claims billing. Maybe it says drug not appropriate for location. Well, okay, if I'm the pharmacy tech, like, what the hell does that mean? Does that mean that this person, like, our pharmacy is not in network for them? Does that mean that this is a specialty medication and only a specialty pharmacy can dispense it based on their plan? That's how it's coded. Does that mean like a variety of things? I don't actually know what that means, but that's the little alert that's going to come up on the screen. Or maybe I get this alert instead, non-matched cardholder ID. Okay, well, I don't know. Is it January? Did this person um, check to see if their insurance stayed the same with their company, but like because this is the invisible part, right? The PBM is this middleman. Yeah, okay, your insurance with Blue Cross Blue Shield stayed the same, but now they're contracting with Prime Therapeutics instead of Navitus. And actually your pharmacy cardholder ID has changed, even though your card looks identical, right? Which is absolutely going to lead to a fight at the counter because it's really hard to understand that nothing looks different and your employer told you nothing would change. But in fact, something is different. And we need to figure out what your new pharmacy benefit plan is. Maybe the rejection is not a covered benefit. Submit to Part B. So when I made that comment about some medications do actually get billed through medical benefits, this might be an example of that. So this might be albuterol nebulizers for a kid, because even though albuterol is a medication, if it's going through a nebulizer machine, well, that nebulizer machine was originally paid for under Part B because it's a medical device, and now their Part D plan, I guess this wouldn't be for a kid, this would be for an older person because it's a Medicare example, but their Medicare Part D plan isn't going to pay for a drug because they didn't have anything to do with the device this drug is going through. So make the medical benefit cover it, right? So it's literally just the finger point of we don't want to pay for it, make them pay for it. But like because it's an albuterol prescription, of course, it was prescribed to the pharmacy. Duh, that's where you get drugs, right? So like just a very messy, confusing situation. That again, like how do I explain that to a patient? I feel like I can barely explain that to you guys. I feel like at least one person is looking at me like, what are you talking about? Um, it might be a more simple one. It might say quantity limit exceeded, which is all fine and well. Okay, I guess this insurance only wants to pay for 30 tablets per 30 days, but the prescription's written in a way where it needs 60 tablets for 60 days. So, like, what the heck do we do here now? Do I call back the physician's office and say, hey, can you change this to just 30 tablets, but twice the strength? And I'll teach them to use a pill splitter. But oh, wait, this patient's arthritis is going to prevent them from effectively using this pill splitter, even if I get them the nicest model that we have in store. So, like, what the heck are they going to do? I like, right, the endless things that can go wrong with that. Or maybe they literally just do need a higher dose because they've already failed a lower dose. And while this isn't the most typical thing and isn't the like first line dosing you see in the guideline, it's still absolutely appropriate for this patient. And now it's going to need sort of a prior authorization, but it's not really called that. It's called an exception. And the paperwork might be a little different and the process might be a little different. And like I, as the pharmacist, don't know exactly what that looks like on thousands of plans. But when I call this prescriber, they're really going to expect me to, right, help them be able to navigate that. Maybe it's as straightforward as it is a prior authorization required, but okay, when I call this prescriber to let them know, I'm probably not going to call. I'm probably going to send a fax, right? Because I don't know what portal they need to log into. I don't know if they already have a username for it. I don't, like I I'm probably not going to make a phone call to not be able to answer a single question they have, right? And there is an automated way if I work at a chain pharmacy to send that fax, so I don't have to think about that any harder than that. Um, Maybe it says non-formulary item. Was it a non-formulary item where a PA could still be done? Or is it a non-formulary item meaning doesn't matter what kind of PAs, appeals, anything we go through, they're never going to cover this as specifically carved out from their plan? I don't know, right? So just like that is literally just, I don't know, what was that, half a dozen examples. There are 50, 100 plus codes like that. And none of them are 100% clear, right? Like what they mean. I gave two or three examples for multiple of those and what it could mean. So it ends up with all the information this pharmacist or pharmacy technician has right now is your insurance isn't paying for this right now, which is a really not satisfying thing to be able to tell this patient who's now at your counter expecting to receive a medication. Or maybe you got through all that, right? Like maybe it needed a PA, maybe it got submitted really, really quickly. Okay, fine. Or the patient came back 2 days later. Okay, fine. Now the claim is processing. Okay, and this costs $1 million or $50 or $100, right? And the patient is like, what the heck are you talking about? This is just a cream. How does this cost $100? Well, yeah, your insurance approved it, but it's tier 3 on your formulary. And I don't know why it costs that much because it's a standard of care medication, but this is what your insurance is telling me the price is. I don't set it, right? And maybe if I'm like, not trying to sling 100 scripts a day, depending on where I work. And if it's a busy Monday, maybe I have time to be like, oh, wait, let's look up some coupon options that may or may not currently be available for this medication. Or maybe I know off the top of my head because I dispense enough of this specific product, right? That I know EpiPen is definitely going to have a coupon if we go look online. And now I'm helping them twiddle around with their phone to register for the coupon so the pharmaceutical company can collect all of their information just to give them $20 off a month, right? Or maybe, for me, when I was working in a specialty pharmacy setting, maybe I'm actually setting people up with grant funding. Um, I won't talk about this more here, but like the dirty secret of a lot of these grant funds is like, where does the money come from? Ready for this? Comes from pharmaceutical companies making anonymous donations to these grant funds because they know people can't afford their medicines. And so if it was a cash paying patient, there would have been a copay card. But if you have government provided health care, such as Medicaid, such as Medicare, they're actually not allowed to, like pharmacies aren't allowed to apply copay cards to that because, we have this misguided belief that the patient needs to have some skin in the game if they're using taxpayer dollars, right? So there is no copay card option for someone on Medicare, but they have a 20% of the total cost of the drug copay. So how does a pharmaceutical company incentivize them to still stay on that medication? Well, there's these grant funds that, it's not us, it's not pharma giving a copay card. They're just for people that are really in need and they're independent grant funds. And they are independent grant funds and they're really lovely people to work with. And I've called these places a bajillion times as a specialty pharmacist, but like the money for the most part is coming from pharma and from like a few really well-intended people who like want to donate and help other people and are passionate about certain disease states. But like almost, man, doesn't that feel like such a freaking scam too, right? When you realize 90% of the donations are coming from pharma, it almost feels predatory, right? So anyways, that's all very messy. And then there's this article a while back in The Nation that quoted a pharmacist who worked in, or I think a couple of pharmacists that worked in retail settings, or we call them community pharmacies now. We don't call them retail, but I will say more so than ever, some of them feel like retail, not community pharmacies. Um, and they said a lot of patients get frustrated with the cost of their prescriptions. Understandably, they don't understand their insurance plan. They aren't aware they have a deductible before their regular copayments kick in. And then pharmacists were the ones standing on the other side of that counter, or pharmacy technicians, bearing the brunt of that frustration. And uh, this article is, I don't know, if you want to feel kind of creeped out, almost worth a read. One of these women that's a pharmacist described like customers or patients following her back to her car at the end of her shift to continue to sort of berate her and yell at her about the cost of their medications. I will say it's like not usually that ugly, but she's also not the only pharmacist that's ever had that experience. So it just really creates this like everything about our healthcare system creates this really adversarial relationship between pharmacists and patients. And I think that that has been experienced for a long time. The sort of, I don't know, corollary for you all is we're seeing that trickle into other healthcare spaces too, right? Like we're seeing that in emergency departments with nursing staff there, with physicians that work in emergency rooms, right? Um, we're seeing an increase in violence in hospital settings. We're seeing an increase in mandatory modules to teach you about what to do if someone pulls a gun on you in the hospital, right? And like none of that is normal. And I think that it gets so normalized because we're all taking these modules and we're all, going through these trainings that we forget that it doesn't need to be like this. And an incredible amount of that is related to not quality of care, but cost of care. So just to say that sort of, we certainly saw the early rumblings of that in the pharmacy sphere, but this is across healthcare now. And pharmacists are maybe in a very unique position in that like the money is exchanged at that counter if they're in that community setting. But I think we all, this is something for all of us to think about in healthcare. I just added this comic because the other sort of like, again, with the PBMs getting to be invisible, but like what's really happening here. So I kind of mentioned fourth mail order claims getting denied. We didn't talk about clawbacks. We didn't talk about audit retaliation. We talked a little bit about under reimbursement and patient steering. That's not spelled right. Is this AI generated? Anytime something gets spelled wrong, now I'm like, is this AI generated? I didn't think so, but spelling makes me not trust it. Um, but yeah, we can talk more about any of those things if you guys are curious, like what that looks like. Clawbacks are like a really big topic within pharmacy. I will briefly say what the heck is a clawback. So yeah, our billing happens in real time, but like similar to medical benefits where like a lot of things get figured out 30 days later, sometimes pharmacies 30 days later will receive a message that's like, "Hey, we overpaid you. We didn't want to cover this prescription that we already gave you the money for. We need that money back from a PBM." Which is incredibly hard for people trying to run a local independent business. You can imagine like under any set of circumstances, but certainly with like the increasingly narrowed margins on drugs in our like PBM centric system. And then sort of just tying that further into like pharmacist burnout. So I think burnout across the healthcare professions has become a really hot topic since the time of the pandemic and like the Great Resignation and all of that. Um, this study was conducted, I think, slightly before then. If it was during the pandemic, it was very early in it. Um, this was kind of like a specific subset of pharmacists in that they were working in a specialty setting. So of course you're going to see a higher number of PAs than in a general community setting, but I just think the numbers are staggering, even though it is a unique setting, like that the prior authorization directly delayed prescription filling. And it's like 71% of pharmacists reported that that had happened with, I think it was the most recent claim they had processed or something like that. I forget how they define that. That obtaining that PA resulted in stress, which is incredible because some specialty pharmacy settings, they're not really doing the PA. They're just faxing the office to say a PA needs to be done. Some specialty pharmacy settings, if they're like within an integrated health system and like the pharmacy is part of that system, um, it was like, so in my old role, I was actually filling out prior authorizations and appeals. Um, but that's an incredible number that 63% reported that that was a source of stress. Um, that processing a prescription, meaning if something was going wrong and you were getting a rejection, even though you knew the prior authorization was done correctly, you, when that sort of thing happens, you'll call the insurance company or not the insurance company, the PBM, to try and figure out like, why is this glitching? Do I need to enter some kind of weird code, even though the prior auth was already done and all of the things are right? When you have to make that kind of phone call, it's absolutely going to suck like 20 minutes of your time. And then just pharmacists reporting they felt more like an administrator than a pharmacist. So like the main area, I'm not going to go further. I think this is an interesting study to share just because the numbers are shocking. But the major other themes that you'll see in pharmacist burnout literature, so the rates are really high and very similar to physicians. The rates increased during the pandemic, so that's similar to healthcare workers across the board. And the last thing that's a big theme, which I don't think is particularly fun or relevant, but I included it on here for completeness. There's a lot of um, the papers, if you search for like pharmacist plus burnout in PubMed, will actually be about pharmacists being used to reduce physician burnout in terms of like what roles can pharmacists serve. This comes up a lot, not just related to physician burnout, but also to, I'm sure you guys have heard in other settings, about the sort of upcoming, or I guess already starting, physician shortage. So there are a lot of articles that look at like how can pharmacists sort of supplement physician activities, which I don't know, is a whole other topic, for another time. So I'll just leave that there. But that's everything I plan to cover today. What questions can I answer for you all? Or what parts of this like maybe resonated or didn't resonate, in terms of what you would recommend for the future? Because again, like some of these are sort of pandemic era, and I don't know if that's still meaningful this many years out.
Thank you so much, Shannon. This has been really cool. Off the top of my head, I don't think anything was like extraneous or too much. I thought we talked to Dr. Weisbart earlier today, so he kind of showed us the little flow chart, gave us a look at horizontal and vertical.
Okay.
So it was nice to have that as a prequel to this. But I don't know what others thinks, but I didn't think anything should be left out. I thought it was great. Does anyone have any questions? Go ahead, Zach.
Um, so I guess or I'll just do this. So it's so interesting hearing you go through this and like hearing like pharmacists are like being attacked in parking lots or followed to parking lots. And like in the news, I see like Walgreens is closing, like all these things. I'm like, dang, what's happened? Like the pharmacies, they're in shambles. The whole industry is collapsing. But it seems so intentional that the money's kept out of like the actual physical pharmacy realm and kept in like these actors that seemingly add no value. And it's like we're just creating like pharmacy deserts, all these crazy things. I thought it was just like, I don't know, whatever thing that comes to mind, mismanagement. Um, but this is something that I'm interested in. What have pharmacists as like labor or unions been doing to kind of try to combat that and be like, what can we do to protect our profession and push back against this very intentional like devaluing and defunding of the care, like very important care we provide to our community?
So this is an excellent question. There are very, well, there are there are some unions that represent pharmacists or represent pharmacists in addition to other healthcare professionals. Those tend to be in inpatient settings, so like hospital settings for the most part. When you think about sort of the landscape of community or retail pharmacy, it is mostly these big companies that absolutely are not going to permit unions to get anywhere near them, right? Like the CVS's, the Walgreens, the others that are, closing or have closed, but the like those really large chains that have an incredible amount of power and political power. So occasionally you'll hear like a really wild news story, and like those pharmacists will not have a job the following week. Whoever was involved in releasing it, or, highlighting some of these things. But yeah, the contracts and sort of the power of those organizations are, not super conducive to their employees unionizing. So um, that gets tricky. And then just sort of like confidentiality clauses and things like that. Like that gets really tricky. So you would think that professional organizations like would step up. So it's similar to how like, not whether we love it or hate it, how physicians have the AMA, right? Like there are a few large national, professional pharmacy organizations. These have some of the same problems as the AMA, as you can imagine, in terms of like, I don't know, getting some of your money from large pharmacy chains, or getting some of your money from pharmaceutical companies, right? In terms of who your advertisers are at your events or in your magazines, or, journals. So that gets a little messy. The other thing I guess to keep in mind about pharmacists, I think this is really, really changing in the last 10 years. But historically, it's been like a pretty red profession. Um, so before the like things really, the wheels really got turning on everything that I just presented with vertical integration and sort of these chains just amassing this amount of power. Um, the pharmacists that were maybe most active in their communities and most active within these pharmacy professional societies tended to be the independent pharmacist, mom and pop, and they think of themselves as business owners and, often are in these smaller communities where the chains weren't originally building, right? Because there just wasn't enough script volume there to have the kind of revenue that maybe CVS or Walgreens was looking for originally. Um, so tended to skew a little politically red. Um, Now, as a greater and greater percentage of pharmacists do work for these large chains, if they work in a community setting or in hospital and health system settings, may increasingly be in positions where they're more of like almost a cog in the wheel. We do see that like sort of political shift. Um, Similar to what I think you all are seeing with like physicians and specifically like young physicians, physicians in training, where like, and we see this a lot with dentists too. Like, d dentists tend to think of themselves as like this lone wolf, like I've got my own practice, my own office, right? Whereas, like, that was a thing for physicians too, but like, certainly has shifted a lot more quickly and more dramatically than it has for like dentists, right? So I think that there's a lot of room to engage pharmacists in um, healthcare reform. I think a lot of pharmacists are most interested in very specifically like the PBM component of that, which it's hard to like maybe then draw them it shouldn't be hard, but can be hard to draw them the rest of the way towards single payer. I think professional societies in general tend to not be like big disruptors. Um, and there is so much PBM legislation. So I meant to include this, but I'm glad I didn't based on the amount of time we had. There are some really great examples out of Rhode Island recently, um, different things from different states, but they're on a state level, a lot of states, so I encourage you to look it up within your own state, are doing a lot of things to like further regulate PBMs, and it's often pharmacists and their professional societies pushing for that. But like getting that to connect to single payer is a little bit more like pharmacists still need to be pulled the rest of the way there, is what I find. Did that answer your question? I know that was a little tangential.
Oh no, 100%. I'm just, yeah, always interested to see how professionals are able to change problems they see. So I'm glad that they're able to do it through professional societies because that's something we've talked about as well.
Yeah, there's room, but yeah, professional societies with pharmacists, have the context that pharmacy has historically been a pretty conservative profession. Plus the extra layer of, and I suspect you see this in the physician professional societies too. A lot of the people that take leadership positions within those organizations are doing really well, right? Like they're not the intern at the hospital churning through however many patient discharges and like right suffering through our current system and getting a million calls that people can't get their medication filled because they can't afford it later and asking for new prescriptions long post discharge. The people that tend to be leaders in those professional societies have already had a long and mostly uneventful career, right? Like during a time before things had really gotten out of hand. So it can be tough when some of the folks in leadership roles in professional societies are much more comfortable with what they perceive the status quo to be than a lot of the people who are still in those frontline roles. Yeah, Kenzie?
I was wondering, I know we talked about the community pharmacy experience. I was curious how it varied working like in the hospital for outpatient or inpatient. I actually worked at U of R in ophthalmology for a little while, and I know that sometimes if patients really needed assistance with like affording their prescriptions, we would send them to the outpatient pharmacy because there was more like assistance with cost. And I was just curious if that added kind of a layer of complexity for pharmacists or how that experience was.
Yeah, so I'll start with this one idea and then I'll kind of go back to your broader question. The reason that often hospital or health system pharmacies are able to offer things at more competitive prices or provide additional assistance to patients who might not be able to afford even the more competitive price is thanks to a thing called 340B, which I don't know if you'll have heard much about in your other sessions, but is currently like very much in the crosshairs in terms of sort of targets of legislation. So this is the other thing besides like PBM regulations that pharmacists get really fired up about is the 340B program and some of the like attacks on that. This is not saying that there are no flaws within how 340B is structured, and I think the same person who has covered patents and evergreening may have covered that sometimes in the past and may still do that within one of your sessions. Um, but the 340B program essentially exists so that um, qualifying, whether it's hospitals, free clinics, those types of entities can get drugs at an agreed upon discounted rate with the understanding that they then have the obligation to utilize the savings from that program for it's worded like patients indigenous to their area, whatever, like for patients who have need within their communities, though, is essentially the whatever the legal jargon is, that's meant to mean. So that the 340B dollars is really what funds a lot of hospitals and health systems and free clinics being able to provide drugs at extremely low cost for patients who need those services. To go back to the broader experience of like or broader question of how does the experience compare? So I've worked in pretty much every pharmacy role. I sometimes feel like a unicorn in good and bad ways. Um, but I predominantly my inpatient pharmacy experience was in pediatrics during my time in Chicago, and it's really easy to not notice or not care about the system in that kind of setting, right? Because for the most part, the drugs that you need in the hospital are on formulary, and you don't really have to think about the patient when they go home, other than patients with complex diseases, which is maybe part of why I got so interested in cystic fibrosis and lupus, who do return to you frequently, right? Um, and then you do start to hear the stories of, well, they're back because they couldn't get the medication they needed that normally keeps them out of the hospital. But a lot of the times there's just not as much visibility into the problems with our health system for pharmacists that are sort of in the pocket of the hospital system. Not like in a financial way, but like in the bubble, I guess I should say, of the hospital system. Um, Times that it really did rear its head for me. I remember one time we were trying to discharge a patient on a Friday. And I remember calling at the time, like I barely knew the difference between an insurance company or a PBM. And this was like such a moment that I finally got it. I remember calling their PBM and having this fight of like, this is the only oral medication they can go home on. If you can approve this, I can get them discharged before sort of like close of business and social worker leaves for the day and all these things. If you can approve this oral medication, otherwise, like nothing's going to happen. This patient's still going to be here until Monday at least. I know a hospital bed costs however many $1,000. This medication, yeah, it's expensive, but like it's the whole rest of this course is going to cost less than $500. Like, come on, like on the phone with somebody trying to do this appeal. And it suddenly, like, just whatever they said in their response struck me. Oh, these aren't the same pocket of money. This person only cares about that almost $500 because this is the PBM. And it's not their freaking problem if the health plan has to pay 6 grand more for the hospital bed. That has nothing to do with them or their shareholders. And I think that was such like a clarifying moment for me. And then, of course, like when I transitioned to outpatient clinics and I worked in the cystic fibrosis clinic and in the specialty pharmacy and did a lot of the prior auths and appeals, like that was just death by a thousand cuts, right? Like you're just constantly fighting with insurance companies. And that's when I actually got engaged in single payer advocacy. But yeah, so it's there in the hospital setting if people are paying attention. And if you're, getting really involved in the discharge process as a pharmacist for patients, but you can work as a hospital pharmacist for years and like decades and never think about this stuff. So they're definitely a little more buffered from it, and it can be harder to engage those folks in advocacy if they're not, you know, somehow otherwise connected to pharmacists, like in those community or retail settings? It's a good question.